Hi, everybody. We're going to give it a couple minutes just for folks to join in, and then we will get going. Again, for those of you joining us, we're just going to give it about 2 minutes, and then we will start. All right, so we'll get started, and a few more people join us as we're underway. Welcome, everybody. My name's Tom Walker. I'm the Executive Director here at Encore Outpatient Services. We are a partial hospitalization and intensive outpatient program for adults. We treat substance use disorder through a trauma-specific lens here in Arlington, Virginia. We're also, we were acquired last October in a partnership between Caron Treatment Centers and Maryland Addiction Recovery Center. So this group of three of us that are bringing you this webinar series are really family and working together, and excited to try and provide something that hopefully is a great resource for all of you. Thank you for joining us today in our first in a webinar series. This webinar series, DMV Neighbors in Treatment and Recovery, a spotlight on local resources, programs, and expertise. Every week, we look forward to highlighting a different provider in the DMV region to provide you with some insights and resources you can utilize in your practice to help you adapt to the changes we've all had to adjust to in the wake of COVID-19 pandemic. And we'll have a variety of topics, not all necessarily directly related to COVID-19, but hopefully provide a good chance to learn of all the resources in our region. We will be conducting these sessions in a webinar format. All microphones for participants will be muted. During the presentation, please utilize the Q&A questions and answers, the Q&A feature to ask any questions you may have. We will have time for questions at the end of the presentation. So we'll do a reasonably short presentation followed by a extended Q&A conversation period. Now I would like to welcome our first speaker, Mr. Don Sloane. Don is the owner and founder of Recovery Care Partner, an organization that provides intervention, treatment advocacy and planning, sober coaching, and post-treatment care, and serves the entire DMV region. Don began his post-treatment career in 1984, educating EAP and HR professionals about effective responses to addiction. He is a trained interventionist and certified professional coactive coach who uses his years of experience to help clients, families, and businesses navigate the treatment industry and recovery community. Don will be speaking today on the topic of creative clinical responses to new norms. I'll add in this that, Don is someone that I've long respected, integral and helpful in a lot of the work we do. His team has really been supportive with the clients we see here at Encore, and especially during this time of COVID-19, the services that his team provides, I think are essential. So with that, I'm excited to hear the presentation, and welcome, Don.
Thanks, Tom. Hi, everybody. I am grateful to be here today and help kick off this series. We were talking before the hour started about how excited I am that we're taking a regional approach so that we can share And like Tom said in the opening, the resources that are available to all of us in our respective roles, be it a family member or a practitioner or a member of a team of practitioners. So thank you for allowing me to be here today. I'm going to talk a little bit about what Recovery Care Partner, my company, has been experiencing since COVID. The overview of what Recovery Care Partner does is, like Tom mentioned, we do work prior to intensive inpatient care and post intensive. And Maryland Addiction Recovery, Caron, and Encore and Recovery Care Partner have really been partnering for years now under the rubric of there being a continuum of care. Because as most of us might be aware, for somebody that's trying to manage substance use disorder and or co-occurring mental health issue, there's not a one-stop shop. There's not, here's an individual that needs support, get them support, one and done, everybody goes on their merry way. What research outcome studies tell us is that a continuum of care is the most effective. And our four organizations, Caron, Encore, Mark, and Recovery Care Partner, each do something a little bit different but complementary to one another. So that's the overview of hopefully what I'm going to share with you all. And the desired outcome here is that we collectively be able to yield better results for the people that we serve, for the populations that we serve, or for the family members that we serve. And I saw the list of attendees. I know many of you have children that are in recovery. I know many of you devote some of your time as volunteers to be advocates for helping families get the help that they need for their loved one. So again, the bottom line goal in my mind anyway for our talk today is how can we collectively work better together to support those that need help so that they can have a rich and full life and you guys and the family members can go to sleep at night. Having said that, the first thing I want to share with you is a little bit about what Recovery Care Partner has been seeing since COVID has shifted the norms of our world. We've seen an increase of calls coming in of about 25 to 30% over the last couple of months. And in those calls, the acuity of what's going on with the individual that's struggling seems to be greater than it had been before COVID. We're seeing more mental health involvement with the calls that we're getting. And they seem to be later in the progression of the disease. And I want to demonstrate that by giving a brief case study here. I received a call about 2 weeks into the isolation from a mom who has a 27-year-old son. Alcohol and marijuana are his primary drugs of choice. He had been at Father Martin's Ashley back in February, came out and began drinking again 3 or 4 days after he was out. And the impetus for the mother's call, excuse me, the impetus for the mother's call was her son had become so impaired in a blackout, he ended up on a bridge in downtown Baltimore and almost jumped. They were able to get him before he jumped. So mom's in California, son's in Baltimore, dad's in Maine, and obviously the family was very, very concerned. And at that point in time, because of COVID, the protocols were not set in place yet, because this was very early on, of being able to get him into inpatient treatment. And I was not going to expose myself or any of my staff to go do a face-to-face intervention. So what we were able to do was put in place an accountability structure with this young man. And it started very simply with me. The guidance I gave the parents was to save their son because he was resistant. He had been in treatment. He didn't buy into 12 steps. He didn't think the treatment was of value. I said, tell your son that you're talking to this guy who seems to know what he's talking about. Would you give him a call? And the critical piece there was knowing that if anything was forced on this young man, that he was going to bolt. He was going to disappear because of the constraints of anything being in proximity, physical proximity. We wanted to do a very soft touch, which is kind of antithetical to a traditional intervention process. A couple of days later, the young man called me. It was, again, a very, very light touch. Hey, guy, you know, your parents told me they were concerned about you. What's going on? And many of you, I'm sure, are aware of a communication modality called motivational interviewing, which is simply asking questions, compelling questions of someone to help them self-discover the answer rather than telling them what the answer is. So rather than me saying, you know, call this young man Fred, you're in deep trouble right now, dude. You need to get some help and you need to go to treatment today. Knowing that that wouldn't work, but if I ask him questions to help him self-discover that maybe he needs support, there's a higher likelihood that we can get him there. So what we ended up doing was putting together an accountability structure. He agreed to do SoberLink. He agreed to talk to me every day. And part of that structure was that if he was not able to stay sober, the day he blew positive, and we had a number of criteria set up, that he would agree to go to inpatient treatment. So that the title of today is Creative Ways to Approach the Environment Given What We've Got. And we're having to do this model more and more because, again, not putting any staff at risk or family at risks. So we've created this accountability framework that the desired outcome is it either supports them in staying clean and sober, or if they're not able to achieve what they set out to do, then they, by their own volition, say, yeah, I know I need to go to help, you know, get inpatient help. So that's on the front end side. Just glance at my notes here real quick. And on the post-treatment side, and this is really where the continuum of care kicks in, you know, what Encore does is a level of care that's really appropriate for someone either without inpatient or post-inpatient. And Tommy and his staff and my staff have had many occurrences of this framework over the last number of years, that some folks need a little bit more support than what a PHP or an IOP needs. For example, one of our staff, a recovery care partner, Eric, works with individuals who have executive functions that are new in recovery, that are trying to complete their education in college. So the staff at Encore and Recovery Care Partner dovetail with that individual and with the family to provide a more comprehensive support that either of those entities could provide themselves. Caron has their first year, my first year recovery, which is a great, again, it's proven to be a really remarkable support mechanism, but for some, not for all, it's not enough, or it needs to be augmented. And the framework that Recovery Care Partner, it's a pretty broad framework, employs is similar to what I explained that we did with this young man, Fred, for pre-treatment. When someone comes out of treatment, we start with the commitments they made for their aftercare as kind of entry fee to the arrangement. And within 24, 48 hours after the person is discharged, we meet with that individual, we meet with their family, and we become case manager / accountability person, and we have eyes on everything. And for those of you that are individual practitioners, if you were the referred, we would hopefully have already been engaged with you when they go to treatment or when the protocol is being set up for what the accountability is. With COVID, one of the things I think this is always critical, but it's even more critical now with the constraints that we have with COVID, is communicating with all the providers so that everybody is not necessarily on the same page, because we each do something a little bit differently, but there's cohesiveness in the messaging to the client as well as to the family. Because I don't know if any of you have ever had this experience, but on occasion, families or patients might try to splinter their providers. Is that ever? Yeah, I would imagine you might have some experience with that. And I believe it's incumbent on us as professionals to ensure that we don't knowingly or unknowingly collude with that. I have a gentleman that I've been working with for years now. He's been through multiple treatments in his 50s, and he's just gifted at splintering the family and the practitioners. And the tighter that communication can be, the better the outcome is for the individual. And frequently that's not an easy journey. It's hard for the family. It's hard for practitioners. It takes a lot of time and energy. But the point that I want to make here is, in my experience, the necessity of being in open communication with all the providers. I received a call 2-3 weeks ago from a family who mentioned that they had talked to a treatment provider an inpatient provider up in Connecticut. And as soon as I hung up the phone, I called the provider, I called their admissions, and I said, "Hey, I just got a call from this family, want to let you know." And they said, you're actually calling us to collaborate with us? And I was stunned how stunned they were that someone would do that. It takes zero energy to do that. It allows us to be more effective on the goal here, which is, again, to yield better outcomes for the people that we get to serve. So anyway, I feel like I'm jumping around. Let me back up. So when someone comes out of treatment, we put together a framework that is based on Dr. Robert DuPont's study of what we know to be the most effective triad of services to help somebody early in recovery, which is supporting them and being part of 12-step recovery network, an accountability structure, and random screening. So we put those things in place. Sometimes if they're enrolled in Encore will take care of doing the random screening, and we will be monitoring it, or we will monitor it together. So that's the front end and back end around inpatient treatment. A couple of other things we're seeing. How am I doing on time? A couple more minutes? Okay. Couple of other things that we're seeing on the calls that we're getting is related to the acuity of what's going on with the identified patient. There's an anxiety in the family systems, which is always high, but it seems to be even more exacerbated with the constraints of COVID. And I think part of what's happening here is that for family systems that have had a tolerance level for the behavior of their loved one, having been confined, the tolerance has gone down because there's no escaping it. You know, living with somebody day in and day out where nobody can get, go out and get relief from the insanity that goes on with active addiction. And the way that that's manifesting, at least the way it's that I'm seeing it present, is we need to do this now, we need to do this now. And there's a sense of urgency that's even more than what I was experiencing prior to COVID. So there's a piece of work to be done with the family members to basically be able to convey the notion that sometimes we need to slow down so that we can speed up, because with respect to this disease or these diseases, to make a knee-jerk reaction and try and slam someone into treatment without a comprehensive plan for what's going to go on, A, it rarely works, B, it's financially expensive, and C, it's emotionally expensive. And it further exacerbates trying to get that individual help in a meaningful way that will support them in getting a sustainable recovery. So the first case study that I shared with you, that 27-year-old man, I'm on the phone minimally every other day with both mom and dad because their anxiety is so high, in part because of his near suicide, but also in part because they can't go be with their son. So I think we all need to give due attention to the systemic nature of what's going on a little bit more than we might otherwise as a result of COVID. So I think, give me 1 second to just look at my notes to make sure I didn't forget anything here. Um, I think I'm good. I think I'm going to pause there, and I'm going to pause there and open us up for a dialogue and questions.
So Don, I think the services that you're providing are unique in a number of ways, right? I mean, you all have a direct line into the family system. To your point, you're providing services, pre-treatment, post-treatment, case management throughout, a variety of different levels of care of treatment, and your hands-on at multiple touch points, which, to my point in your intro, really reinforces the care that we're providing in an outpatient level. Helps folks in private practice really have added comfort and structure that's being provided, especially for our more kind of contemplative folks that aren't quite as internally motivated yet. So I'd like to learn a little bit more about how that's playing out in different. I mean, you mentioned the family system. That's a big one, and that's where we struggle with here at Encore, because folks are home all day with their families right now, and it's different. I love my family, but I like being an adult and being out of the house. So imagine that. While trying to be in early recovery and what have you. So I guess what are some of the things you're seeing, if you can elaborate on the family system? And as a second question, or first, however you want to go, I'm interested, you're seeing an increase in need for your services. Where are you seeing the greatest need?
Okay, thanks, Tom. Let me answer the second question first. One of the services that I kind of pinch myself every time we're asked to do it is sober companion work when people are leaving treatment. This is where we will pick the individual up from wherever they're being discharged from, drive them or fly. Not flying right now, not yet, but drive them to their home, wherever it is. And then one of my staff lives with them for as little as a week. We've done it for a couple of months, to help the person get acclimated. And that's the biggest increase of request for service. The population, or the demographic of that population, is predominantly folks 50 and older. We're not getting that request for adolescents or young adults or middle-aged folks. And so that's by far the biggest increase we're seeing. The second increase, Tom, that we're seeing is what you spoke to about doing some version of the recovery care monitoring, which is the accountability 12-step and random screening. And we're flexing our model that we've had for many years now to dovetail with my first year recovery at Caron, to dovetail with some of the clients at Encore, as well as Mark. And the work that we do there is your staff, Mark's staff, has family therapists that does whatever with the family. We augment that. I think the easiest way I can explain it is to say we fill in the white space between what you and Caron and Mark don't do. And if there are gaps there, and it varies from family system to family system, but it's that's the best way I can describe it. We just fill in the white space between what you guys don't do. And your first question, I'm sorry, ask me again what the first question was.
I was just asking about what you're seeing specifically in those family dynamics. If you could elaborate. You talked about increased urgency, which I agree. We're seeing that too, but it's less. We don't have the line of sight you do. So, are there any other things that you're seeing within the home dynamics, family dynamics?
Sure. One thing that is appearing more frequently than it did prior to COVID is, I'm pausing to think of the language to describe this. If many folks have been acculturated, trained from their family and from their life's journey to live most of their life from the neck up. In other words, they're thinkers, and they want to figure out what we need to do to fix whatever the challenge is. And then there are those that, you know, live more from an emotional, gosh, I'm so frightened for my child. So maybe tactical versus emotional. Neither is right or wrong or good or bad. We all are wired a little bit differently. What we're seeing is more, can you just tell me how to fix this? And so there's this kind of stiff arm from the family system saying, this is not my problem, it's their problem, and more resistance to getting the family engaged in the process of recovery. It's like, this is not my problem. I'm living I had one dad say, I'm happy. My life is great. My daughter's almost dead and I know we need to do something, but I'm good. And dealing with that level of, I don't know that it's denial, but it's absence of access to a broader experience of what's going on. So we're having to spend a lot of time around that particular dynamic.
Thanks. I think it kind of dovetails into some questions that are being asked. Really two things. So how are you managing this with COVID-19? Are you providing services in person, virtually? Are you doing in-person interventions? How is that, virtual platform changing your approach with this stuff? I know, getting ready for this, you're spending many hours a day in virtual services. And then another question that was asked via the Q&A here is, if an intervention fails, do you reach out to the individual to check in and reestablish contact? So I know, like, that's three questions in one, but understanding your model, I think, so how are you providing services right now?
Mm-hmm.
How is virtual changing that? And then what do you do, on the back end of an intervention or a meeting where you're attempting to help someone find out?
Okay. So with respect to intervention, 7 weeks went by and we did not do any face-to-face interventions. We did not do any traditional interventions. I made the decision based on the guidance as I understood it to how not to put any of my staff or any of our clients in harm's way, potentially. And in that 7-week window, the first case study is how we were managing interventions if somebody called. I have 4 interventions that are prepared, everything's lined up, all the preparation has been done, and we're waiting for the world to be safe. My first face-to-face intervention I did 2 weeks ago, this coming Saturday. It was interesting because my guidance for what's safe relative to COVID, my primary guidance is Dr. Joe Garbley, who's the medical director at Caron in Pennsylvania. Dr. Garbley did his residency in the mid-'80s in San Francisco at the height of the AIDS epidemic, and is one of the most well-versed, educated folks I know on how to manage in a safe way through the environment. So Joe says you can do it. He said, Don, you can go do the intervention. Face masks are not negotiable. It needs to be an area where, say, minimum 6 feet, preferably with a breeze like a screened-in porch. So the intervention I did, the family had a screened-in porch. And interestingly, there were 12 participants plus the patient. 2 of the participants were young men in their mid-20s. And they said, Don, I'm not wearing a face mask. She needs to see my face to see my emotions, which was kind of made sense on one hand. And I didn't have a reference point to see whether the mask would make a difference or not. And I said, well, if you want to be there, you need to wear a mask. Otherwise, we're not going to do the intervention. So they agreed. And as it turned out, I would say there might have been a 5% decrement in the efficacy of the intervention, because the emotions did come through, even with the masks there. That didn't come through the mask, but the eyes were able to convey. And the woman accepted the help and went to treatment that day. So based on a data set of 1, I would say that there's no downside to doing the interventions with the current guidelines. I'm doing an intervention on Saturday in Philly, and on Sunday in Baltimore. Same thing. if you want this to happen, the only way it's going to happen is with face masks. Normally, we transport the person to wherever they're going to go to treatment. We're not doing transports right now. I was told, do not get in a closed environment for more than 5 minutes with anybody that you don't know where they've been. So we're having the family member do the transport, which is not the preferred, but given the environment, that's what we're doing for the time being. So that's for the intervention work. For the recovery care monitoring, we're doing virtually. It's been seamless. I don't think it's lost any of the efficacy of the model. If anything, it seems to have enhanced it. I have a group of executives that I work with typically every 2 weeks. We're meeting every night, and the group varies from 15 to 20 people to 12 to 20 people have said, whatever we're doing here, this is working better than anything I've ever done. And these are people that have been sober 3 or 4 years down to a couple of weeks. So the flexibility of being able to be in a meeting or be in a support group at 8 o'clock and be finishing dinner at 7:58 seems to be working for people. So that's the virtual question. When we do an intervention and someone refuses to accept the help at the time of the intervention, I believe, is that what the question was? What do we do? Mm-hmm. Okay. The way recovery care partner agrees to do an intervention includes a year of support from the time that we're engaged. So if we facilitate the intervention and the person refuses help, we stick with the family. Typically there's a phone call minimally once a week with all of the intervention participants to support them in not colluding with the person who is intervened upon. Sometimes we include the person that's intervened. We'll say there's a model of intervention called the ARISE model. We'll let the person know, we're talking Tuesday night at 7:30 about how to deal with you not accepting the help. You're welcome to join the call or not. And we will stick with the person and the family. My lawyers made me, in the agreement, say that it's a year, but we stick with them until the family says, you know what, we're done, or the person accepts help. The first case study I gave you, Fred, the 27-year-old, he did relapse. He did not agree to keep his commitment to go to treatment. He and I had some very frank conversations, and he said, I'm not working with you anymore. I said, okay. But 36 hours after he told me that, I dropped him a text and said, hey, Fred, just thinking about you. Hope you're doing okay. He wrote back almost immediately, gosh, Don, I appreciate you reaching out to me. We've been doing that every day. So we will stick with the process and the family system until somebody tells us to go away, because we know frequently it's not a one and done. It takes days, weeks, months sometimes of support for somebody to go, you know what, maybe getting help is better than what I've got right now. Did I answer those questions?
Yeah, you did. Thank you.
Yeah.
You know, it's funny, I've been saying since the beginning of, you know, social distancing and this, you know, this pandemic, that it's almost an ideal time for residential treatment from a standpoint of, you know, you have more freedom to go receive that treatment. And they're really, I mean, they're safe environments. I mean, these are treatment environments that are highly governed by, you know, CDC policy and protocol. And to your point, you know, Dr. Garbley and, you know, some of the brightest minds and most informed folks that are making decisions on how to protect staff and clients. But I'm wondering what kind of, and this is a question that actually came in, but what kind of, you know, opposition or what kind of, you know, reasons are people presenting with to not go into treatment? And I can share some of my own experience from this side of the world, but I'm wondering what you're saying. You know, say, okay, you need help, things are getting worse. You know, we see this mental health crisis unfolding in front of us, and folks, I think, getting sicker with fewer consequences right now because there's less going on. So what are you hearing as far as opposition to getting help, or, you know, what are the actual obstacles to people getting what they need?
In general or relative to COVID or both?
Let's say both. I mean, I think, yeah, in general, and then how has that changed because of COVID? Or
Okay.
what's
So in general, the most common um, points of resistance, which I think is what you're asking about, are anywhere from my shoelace broke this morning to I'm going to get fired from my job, or my spouse is going to leave me, or my kids are never going to talk to me again. So, and one of the determinants, excuse me, is how far progressed the individual's disease is when they're intervened upon. So, for example, if it's relatively early in the progression of their disease and the major components of their life are still intact, family still intact, job or education is still intact, and it's just that the edges are beginning to get ruffled, it's the objection is, I don't know why you're doing this. I still have a job. I still have a family. Okay, yeah, I know. I disappointed my wife 3 times this year, my kids, whatever, but I got this. And the resistance, the point of resistance is the individual's inability as a result of how their reasoning has been impaired to acknowledge and connect the dots between their relationship with whatever they're using, alcohol or drugs, and the circumstances that left the family and friends having the intervention, to think that they're concerned enough. So it's just kind of garden variety, unremarkable. I'm not able to see what you guys are talking about. And then as, excuse me, as the disease progresses, and as that individual's world circumstances begin to become more acute, loss of job or threat of loss of job, or the depression as a result of their addiction gets to the degree that they're not able to function at the level they were able to 2 years prior. It's like, well, I know I need help, but alcohol is, the only way I can sleep right now is to smoke a joint before I go to bed. And you're asking me to take away the very thing that's helping me get through how miserable my life is right now. So a faulty belief system that the individual develops, and that can manifest in a variety of ways, but the base of that is the individual develops a faulty belief system of rationalization for the things that they're trying to justify. And then in late stage, it's, I just had an intervention probably 3 months ago, 4, 5, 6 months ago now. The individual I intervened on, he's in his 60s, early 60s. He said, you know what? I was in treatment 20 years ago. It didn't work. I know I need help, but I've screwed my life up so bad. Why would I bother to do this now? So there's this sense of futility, that there's no, this gentleman, he said, I don't even know why I'm still here. Why would we waste time and money for somebody like me? So there's absolute degradation of any sense of self. And again, I could go for 2 hours about all the things that I've said, but I think understanding the foundations for whatever the story is a little bit more meaningful. So those are the things, but you asked me another question in there.
Yeah, with COVID, what do you?
Very little. Because again, we haven't been doing a lot of interventions. The couple that we've been planning, because when I do a planning for an intervention, one of the questions that I ask is, okay, folks, let's say that, Betty acknowledges that she needs help. What is she going to come up with her excuses for not going? Yeah, I know I need help, but I can't go because. Sometimes the answer has been, I don't feel safe leaving the house because of COVID. But I don't think that, I'm not having enough of an experience to know how prevalent that is, because the response to that is really simple. It's like, treatment's safer than where you are right now. It's a contained environment. So no substantive difference with COVID that I'm aware of or experiencing.
Interesting. Yeah, that's subjectively how I've seen this as well. That at least on a residential level of care side, there's a willingness, or at least less of an obstacle than I would have anticipated because of COVID. Because again, they're generally safe, regulated environments and perceived as such, and we can articulate why that is.
Mm-hmm.
what I've found on the outpatient side of the world, in talking with clinicians in the region, is that they're saying they have seen an increase in, acuity and severity of substance use and mental health issues, but that they are hesitant to recommend an outpatient level of care until in-person services resume.
Hmm.
And it's interesting. We've continued to offer to some degree some type of in-person touch point.
Mhm.
And for the bulk of this pandemic, folks haven't been really interested in coming in person, and that makes absolute sense, right? It's scary,
Right.
and now we're starting to see, an increase of folks that are more and more willing. But when I talk about why your services are so important right now, it's that piece. I think that there's a landscape out there where there's really good treatment happening, primary treatment, residential, and then the aftercare piece. We don't have the levels of care we used to,
Mhm.
quite frankly. So yeah, there's not a question in there, but I'm wondering if there's something you relate to, if you have a
I
perspective
have
on
some
it.
thoughts. I have a couple of thoughts. One thought is that our collective conscious, not just within the realm of treatment and substance use disorder and mental health issues, but our collective conscious of mankind right now is experiencing a degree of grief. All of us are, um, because of all of the impact of COVID. And there are countless articles that I've read and studies that I've read in the past few weeks that support this. And part of the grief is not knowing. None of us know whether there's going to be a second wave. None of us know whether it's safe to go to the grocery store or not. None of us know, when I put gas in my motorcycle the other day, whether I had to go sterilize my hand immediately because I was afraid I was going to touch my nose while I was riding home. So there's this omnipresent not knowing. And if we intersect that with what is it like to live with active addiction, which is also not knowing, because part of the anxiety of part of the impact of active addiction is, good dad going to come home, or is drunk dad going to come home? Is my child going to hurt themselves again, or are they back on track? Do I trust what they said or not? So there's an inherent level of anxiety and ambiguity, emotional ambiguity, that comes with active addiction and early recovery. Many of you, from what I saw on the list, know me and my story. For those of you who don't, I'm a recovering person. I've been sober for a little over 36 years. My one brother didn't trust me till I was about 7 or 8 years sober. So if we take that axis and we intersect that with the ambiguity of COVID, we have, it's not 1 and 1 is 2, it's 1 and 1 is 7. And what part of the acuity that you said that you're seeing in your experience, Tom, and that we're seeing in our practice, is a reflection of that intersection in large part. So with families, with the family system, I think it's incumbent on any of us that are practitioners that we acknowledge this additional factor of COVID with the intersection of whatever's going on in the family system with addiction or mental health. I'm of the experience, and therefore the belief, that when we acknowledge that, and when we provide space for this conversation to happen, then it takes some of the charge out of it, so that we can get focused on what the work at hand is, which is what do we need to do to help stabilize our loved one or get them the help that they need. I don't know if that makes sense or not, but
No, it
hopefully it
does,
does.
and it begs the question of, so as professionals in this field, and I know I've seen the folks that registered, and there are a lot of experts and folks that are watching right now, but for the sake of conversation, then, so how do we as professionals support folks in getting to that point, and helping a loved one move towards getting the help they need? And just add that, it's a concern of mine that I keep talking to people like, when things go back to normal, which whatever that means at this point, or, we have increase in freedom of movement and congregation, that, there's going to be this flood of people that need help. And I think that's true to some degree. Now, historically in our field, the number of people needing help doesn't always translate into the number of people getting help, right? There's seeking services is difficult. But my worry is, if that's true, that there's going to be a high level of acuity and, severity of symptoms when this is over. And, much like we fear with hospitals and COVID getting, overflowing the hospitals, overflowing the system. So I guess I'm asking, what do we do now to help motivate people towards the treatment they need to avoid that overflow? And how do you know when someone needs that level of care, needs that treatment, when that, when we should be pushing for that?
So you're really good at asking multi-pronged questions.
Well, I'm used to talking with just having a conversation, and neither of us really answer each other's questions. So
Right. So what were the questions again? So about acuity, about how to prepare for the onslaught.
Yeah. So I'm worried there's a lot of people that need more help than they're getting right now, and that we're waiting too long. So how do we identify those people? And
so let me do one at a time, because I'm old and I forget stuff. So it's very common for me to be asked the question, or hear the statement, Don, I'm not sure whether my son is an alcoholic or not, or an addict or not. Yeah. And don't we have to figure that out first? And this is my answer to your question, is whether somebody has the tag or the diagnosis of an addict or an alcoholic or substance use disorder, in my opinion, is irrelevant. It's simply a tag. What I invite people to do is look at the behaviors. Are the behaviors okay or not? Are the behaviors getting worse, or meaning more adverse consequences, or not? And if there's a definitive and measurable, yes, in the last 3 weeks, behavior has gotten twice as bad, and the angle of the increase is getting more acute. That's what I look for about, is it time to do something or not? Okay. The intersection of that with COVID is, it's hard to tell whether somebody who is self-medicating, doesn't have the disease, and has anxiety and depression, and their depression is being exacerbated because of the social distancing and the constraints that COVID have given us. There's no way to parse that out. We all, many of us know, there's no way to parse out what's going on until we get that person somewhere to get clean, to see what's left, right? So I think one of your questions was, what can we do to address that first thing I just said? I can tell you what works for me and for the clients we work with, which is 110%, 150% transparency. And what that sounds like for me right now is saying, I don't know. We are in uncharted territories about the impact of COVID, short and mid and long term, relative to addiction. We don't know. But I can tell you this is where we're going to start. And where we start is with the behaviors are concerning enough that it's time to take action. And the first action is to get your loved one someplace where they can be stabilized enough so that we can see what's left. And if there's trauma from COVID, we can deal with that. Encore, you guys are expert at that. If there's substance, if your loved one has the diagnosis, the disease of substance use disorder in conjunction with the trauma, we can deal with that. But step 0 is to determine what it is that needs to be addressed, rather than assuming it's addiction or it's depression or it's trauma. We need to figure that out first. And the transparency, in my opinion, is being blunt, saying, I don't know. And I cannot tell you, and I don't say this to be self-aggrandizing, maybe a little bit, but I can't tell you how many families I talk to on a weekly basis that say, Don, we've talked to 7 other providers. Nobody's ever been this honest with us. They tell us we need to go this way, and our gut says, no, that's not it. So I'll say it one last time and then shut up. Just be transparent from whatever your seat is, whether you're a doc or a psychiatrist or a psychologist or an interventionist or IOP, because again, I'm going to go back to the ambiguity that we're living with. We human beings are not hardwired to deal with ambiguity. We do not deal with ambiguity well. And being honest with somebody and saying, I don't know, takes away the ambiguity. It's like relief.
So how do we deal with our own fear? You bring up something that's great. You do this a lot. You made some good points. I have a couple I pulled out of that. So from a clinical perspective, I think sometimes the concern might be that if we are too direct or we tell too much of the truth, we might lose that person, right?
Mm-hmm.
They might react and there's no undoing that. How do we manage that? How do we have that conversation? How do we speak honestly? And, you know
me well enough. You know how I'm going to answer this. So I worked in the field from 1985 to 1990, and I left for 18 years. About 12 years ago, I came back, and I worked in a totally unrelated field. And when I came back to work in the treatment, it was because it was a calling for me, and remains a calling for me. And I wanted to take my experience and the gifts that I've been given and do something to help others. And when I came back to do this, I did not have a relationship with any treatment center or therapist. Nobody knew who the hell Don Sloan was. And I jumped off the edge of a cliff professionally. And the value proposition that I jumped off with was to be authentic and to be honest and see whether it worked out or not. It's been 12 years, it's worked out. I've been blessed to touch the lives that I've been able to touch and be touched by the lives that I've had the opportunity to work with. And for me, whether I get to another intervention this week or next week, or whether we retain the clients that we have, is about 7th on my list of priorities. The first on my list of priorities is what can we do, not Don Sloan, a recovery care partner, but what can we do, and we being the professionals that I'm aligned with, to collectively help this individual not die from whatever they're dealing with. That's the first measure. So I don't know whether if what I'm saying is controversial or not, and to be truthful, I really don't care. It's what I got. The answer to your question, Tom, is if I pay attention to what in my intellect and in my heart, I believe is the best thing for that family, from, yeah, we can help you, to nope, we're not the right people, here's who I think you should call. If I can't answer that question affirmatively, then I'm not doing it.
No, and I appreciate that about you. And I think the point of this type of format is so we all get to really know each other and know where we're good fits and working with each other. I've always felt like if you project a caring concern, and if your intentions really are that you want what's best for the person in the family system, that you can tell the truth and maintain engagement and keep them a part of and keep them in the process one way or another. So we're very much aligned that way. You said something else a few minutes ago, and I wrote it down because it stood out to me. You were talking about how COVID-19, that during this, it's really hard to parse out whether, what someone is going through is because of the separateness and the pandemic and the isolation and the increase in drinking and depression, anxiety, eating, all of the different things people are experiencing. You said it's difficult to parse out whether that's because of this or whether it's what we would traditionally, categorize as a substance use disorder, mild, moderate, severe. Did I hear you say that it doesn't really, you didn't say it doesn't matter, but it sounded like to me you were saying that actually treatment is the way we determine what it is. Is that accurate or what?
I think so. If I followed you, following what you followed me saying,
I'm gonna get better. I'm gonna get better at this every week, people.
I, what I was suggesting is the step zero, the place to start is with an assessment that will inform what type of and what level of care is best suited for that individual. You know, it's one of the things I did when I was away is I owned and operated a boutique management consulting firm. And in the initial meeting, I would be with somebody or someone's in the C-suite of the organization. And I would come into the initial meeting and they would explain to me what the problem was that they were facing. And then they would follow up with explaining what the solution was. And I would say, I'm a little confused why I'm here, because if you already know what the solution is, you don't need a consultant. And inevitably what would happen at that point is the first piece of work was to figure out what the problem was, because they really didn't know. They know what they thought it was, and rarely was that accurate. And so if we apply that framework, if you will, to the individuals that we support, again, if it's a 54-year-old Caucasian guy that's only drank alcohol, we know how to deal with that. There's nothing much to figure out. But if we have a 27-year-old who was not acting out, up till 6 weeks ago, and he's been smoking pot every day because he's out of his mind and is experiencing marijuana-induced psychosis and putting his fist through the wall in his parents' house, and the parents and tell me, you hear this, we don't know who this person is all of a sudden. He was a straight A student, he was an athlete, he was this, he was that, and now he won't get out of the basement and is putting holes through the wall. Well, we got to figure out, is it marijuana-induced psychosis? Or because he's 22 and there's a familial history for mental health issues, is he beginning to manifest because he's in the age bracket where it would begin to show that there's some mental health issues going on? So to throw somebody like that into a Caron's a bad example because they would assess it, but to just a drug and alcohol treatment provider to get him taken care of with the pot and totally miss whatever mental health is beginning to manifest is irresponsible, in my opinion. The first step, step zero, figure out what it is that we're trying to address before we design what it is, how we're going to address it. Is that what you were asking me?
Yes, and you answered it. What I heard and the answer you gave were different, and I'm glad that I came back and asked it.
Okay.
And I, obviously I agree entirely. And I think too, whether we're talking about, traditional, therapy or treatment or the work you're doing in intervention and, coaching and consulting work, an evaluation and assessment is the lowest level of commitment as well. And it's the best way to develop a starting point. So I think that as we're sitting in these uncertain times, looking at when we're unsure, bringing in, another, person or group of people that can provide different perspective is probably the best first step and thing to do to provide guidance. So I appreciate that. I also,
so let me take 30 seconds because I know we're out of time, if I could. This is also a way to help people get to help that are resistant to going to treatment. This 27-year-old young man that I've mentioned a number of times, my next move with him is to say, you're not able to get on track. You know it. I don't know what's going on with you. Why don't you go to Caron for a week or 10 days? Get assessed, figure out what the heck's going on. And you might not even need to be there. You might just need some medication for whatever you got going on. But let's find out what's going on. So it's another tool to help people get to help.
Thanks, Don. And thank you very much for being the first to go in this series. I am grateful that it was you and someone I have good rapport with, and that you gave us a shot with this. Hopefully it was helpful to everyone that joined us. Thank you for being here. Just a couple of notes before we go ahead and wrap up and close this out. please join us next week, same day, same time, as we welcome Dr. Cliff Sussman, who will be speaking on internet and video game addiction during COVID-19. Registration for that is currently open. In the meantime, should you need anything at all, whether it's treatment, whether it's evaluations, whether you want to just discuss the state of things in our field, whatever help we can provide, please feel free to reach out to myself, Mallory Schwartzman from MARC, as well as Jess Ayer out in Maryland for Caron, and James Flintjiff for DC and Virginia. We're here. We're resources for you. I'm interested in connecting and learning what you're doing and your best practices. Also, as this series continues, if you have suggestions for folks in our community that you'd really like to hear from, that you think our experts in a way or have a perspective that would contribute to an event like this, please feel free to message me and recommend them. We're always looking for folks. So again, Don, thank you so much, my friend.
My pleasure. Thank you for asking me.
Take care, everybody.
Bye-bye.